All right, thank you everybody. Thank you, Jenny, and thank you, HealthTree, for bringing us all together. This has really been a really wonderful conference so far. It's been so nice to see many of our patients, familiar faces from clinic, and nice to have physicians here from not just Penn, but Jefferson and even up in New York and Mount Sinai. So I'm going to talk about bispecific antibodies. And I wanted just first to deconvolute that term a little bit for everybody, because it's confusing to keep track of all these different drugs and how they work, and we just throw these long words around. And so I wanted just to set the stage first, understanding what are antibodies and where bispecific antibodies fit in alongside some of the other types of therapies we've been talking about. So antibodies are proteins that our immune system makes to fight infections. And so antibodies, our body makes antibodies against viruses, and so an antibody is a biomolecule that can recognize a target. And so about 30 years ago, folks figured out, oh, your body makes antibodies against different bugs like flu and whatnot. What if we could engineer an antibody against a cancer cell? And so the idea there is that cancer cells have molecules on their surface, and we could engineer an antibody against that target on the surface of the cancer cell to use to treat cancer. And there are many, many antibodies that are now used to treat cancer. And so if we think in multiple myeloma, there are several conventional monoclonal antibodies that have been developed: daratumumab, isatuximab, elotuzumab, and these recognize a target on the surface of the myeloma cell like I've depicted here. And these are all immunotherapies, and so the idea of these drugs is that they help our immune system recognize the myeloma cells. And so a regular antibody like DARA or ISA or ELO, it binds to the target on the myeloma cell, and that antibody then recruits the immune system to the myeloma cell. And in the case of a regular antibody, the immune system cells that are recruited are a specific subset of cells. We call them NK cells, or natural killer cells, or macrophages. And then once the antibody brings those immune system cells to the myeloma cell, the immune system cell can kill the myeloma cell. Now, when we think about the conventional monoclonal antibodies, they are effective, but the killing of myeloma cells they induce is relatively weak. And so if you take a good conventional monoclonal antibody like daratumumab or isatuximab, and you just give that to a patient with relapsed myeloma, you can get a response in about 30% of patients, 20 to 30% of patients, which is not very high. And those responses tend to be partial responses. And so as a result, these conventional monoclonal antibodies are usually used in combination. They're not very effective as therapies used alone. So now what we've learned over the years is that a different arm of the immune system called T cells, they are more active or can induce a stronger killing effect against cancer cells than those other immune system cells I was mentioning, macrophages and natural killer cells. The problem is that antibodies do not naturally recruit T cells, and so you have to do some funny business to get an antibody to bring a T cell to the multiple myeloma cell. So the way you do that, what's been figured out how to do that, is to give the antibody two targets. And so you see here we've represented that as two different colors. And so you give the antibody two targets, one on the myeloma cell and then the other on the T cell. And so we call that a bispecific antibody because the antibody has two different specificities or two different targets. And so when you do that, you bring the T cell to the myeloma cell rather than those other types of immune system cells. And it turns out the T cells can lead to a stronger response, a stronger killing response against the myeloma cell. So when you give a bispecific antibody that grabs a T cell and brings it to the myeloma cell, and you give it as a single agent, instead of a response in about 30% of patients, you get responses in 60 to 70% of patients. And instead of those responses being partial responses, they tend to be complete responses. And so you get much more strong killing of myeloma cells and complete killing of myeloma cells. And the responses last a long time. And so what we've learned about the bispecific antibodies is you can give them, and when they work very quickly, and they usually last for a long time. And so for some of the ones that have been developed so far, it looks like about 2 years on average they can work alone. But that's just an average. And so we unfortunately have some patients who are on bispecific antibodies who who they don't work for very long. But then you have another group of patients where they've been on them for 4, 5, 6 years even, and they're still working. And so you see a wide range of responses. So if we compare bispecific antibodies to CAR T cells, you see that they're kind of the same concept. And so a bispecific antibody, the drug, the antibody, is bringing the T cell and the myeloma cell together. This is similar to CAR T cells, where you're using genetic engineering to basically plop an antibody on the end of a CAR T cell and then give the whole cell back to a patient. With a bispecific antibody, a drug is doing that work inside the patient's body. And in fact, it's kind of amazing that you see from 2011 or so, when the first clinical results with CAR T cells were first published, how quickly we went from having to do this complex genetic engineering exercise with CAR T cells to maybe 2016, 2017, we had some of the first patients getting bispecific antibodies that you can get the same kind of activation of T cells against myeloma, but just with an injection that you would give the patient, as opposed to having to do the complex genetic engineering that is needed for CAR T cell therapy. So what makes bispecific antibodies so exciting is that they are similar to CAR T cells in how potently they can activate the immune system. But they can do it in a way that's what we say off the shelf. So you don't have to make a new product for each individual patient. You can just have the drug sitting in your pharmacy and give it to patients right away as a subcutaneous injection. So that makes it much simpler. You don't need the patient-specific manufacturing. They're given as subcutaneous injections, some of them. And compared to CAR T cells, when you give CAR T cells, the T cells go in the body and they start growing, and it's a little bit unpredictable what happens once you put that living drug into a patient. And as a result, the toxicity profile of CAR T cells is a little bit unpredictable. With bispecific antibodies, it's a little bit less severe, and you have a little bit more control over it, because if someone starts having an adverse reaction, you can just stop giving the medicine, and with time, it will get better. Now, the flip side is that it does seem like CAR T cells are also a little bit more potent. So there's two sides to every coin. And so while with bispecific antibodies, they are much better than conventional antibodies as therapies, they're maybe not quite as potent as CAR T cells, but they're also simpler to use than CAR T cells and maybe more accessible to more patients. Also, at least right now, we have multiple targets for bispecific antibodies. So right now, all the CAR T cells that are available target BCMA, but with bispecific antibodies, we have other targets such as GPRC5D, and then some that are not FDA approved yet, but are in development that are exciting. So these are just a partial list of the different bispecific antibodies that are in development for multiple myeloma. And I've listed here the ones with asterisks are the ones that are FDA approved. And so the ones that target BCMA, teclistamab, elranatamab, linvoseltamab are FDA approved. There's also one that has a different target on the cell surface that we'll talk about called GPRC5D. Talquetamab is the drug that targets that. And then there's one that's not FDA approved yet, but I think is very promising and that we've given to patients as part of clinical trials, called cevostamab, that targets another cryptically named target called FcRH5. So right now, bispecific antibodies are FDA approved for what we call late-line therapy. So these are for patients who have had 4 or more prior therapies for multiple myeloma. But as we'll talk about, one of the next exciting things that's happening is their use earlier on. So where do we currently use bispecific antibodies for treatment of myeloma? So one common use is for late-line therapy for patients instead of using CAR T cells. And so if you think about a patient who has been through 3 lines of standard myeloma therapy, as I've listed here, the 3rd line is not working anymore, and so we decide in the 4th line of therapy to use a bispecific antibody. That's roughly where they're approved by the FDA. And you say, okay, well, why wouldn't we use CAR T cells for that patient? Well, for some patients, they don't have access to a CAR T cell center, so they're not near one of the places that does CAR T cell therapy. In other cases, the myeloma is growing too rapidly because CAR T cell therapy takes several weeks at least to arrange for a patient. If the myeloma is growing too rapidly, you need something that's going to work right away. A bispecific antibody is a great answer. And then there are some patients who have access to CAR T cell therapy and they are good candidates for it, but they just are uncomfortable with the risks. And I think it's good that patients have more options and can choose between these options. And so someone who wants to use a potent therapy but are uncomfortable with the risks of CAR T cell therapy, bispecific antibodies are a great option. Another situation in which we're using bispecific antibodies are for patients who have already had CAR T-cell therapies and have had their disease grow after CAR T-cell therapy. So CAR T-cells are amazing. Maybe they're curing some patients with multiple myeloma, but we think what we're finding is that many, if not most, patients eventually have their disease progress after CAR T-cell therapy. So bispecific antibodies are a great option after CAR T-cells stop working. So take that same patient in their 4th line of therapy, they got CAR T-cells that targeted BCMA. They later relapsed, they can get a bispecific antibody, maybe targeting a different target than BCMA, like GPRC5D, or maybe targeting BCMA if it's been a long time since the CAR T-cells were given. And these are results from a clinical trial of talquetamab, which is the bispecific antibody that targets GPRC5D. And on the right column over there, you see the group of patients in this trial that received talquetamab after getting a prior immunotherapy like CAR T-cells. And you see that 67% of patients, 2 out of 3, had a good response to that antibody, even though they had previously had another potent immunotherapy. And so that's a really great result to be able to give for somebody who has already relapsed after CAR T-cell therapy. Another use that we're getting more comfortable with now is using bispecific antibodies as what we call a bridge to CAR T-cell therapy. So I mentioned the situation where somebody's disease might be growing too rapidly to get to CAR T-cells because CAR T-cells take several weeks to manufacture. But what we have is some recent data in the last year or so showing that if you take a patient who's relapsing after 3 lines of therapy with really rapidly growing disease, well, maybe you can quickly collect those T cells and start the manufacturing process and then give them a bispecific antibody. And especially it's appealing if you can do those therapies against 2 different targets. So somebody's disease progressing rapidly, collect the T cells, give talquetamab that targets GPRC5D. It'll work quickly because it's off the shelf. And then when the CAR T cells are ready, you can give the patient the CAR T cells that target BCMA. And that's a use of bispecific antibodies that we're doing more of, and it allows patients even with really rapidly progressive disease to have access to CAR T cells because we have this highly effective therapy that we can use to bridge them to the point when the CAR T cells can be manufactured. All right, so some challenges with bispecific antibodies. So while I mentioned that they are more accessible than CAR T cells because you can get them in places that don't have all the infrastructure that's needed for CAR T-cell therapy, they still require some specialized expertise and infrastructure. So you still get cytokine release syndrome with bispecific antibodies, which is the same syndrome you get with CAR T-cells when the T-cells are getting activated in the body. It tends to be milder with bispecific antibodies, but still officially the products that have been FDA approved say you need to start this drug in the hospital. So you need to be at a place where you can get the drug in the hospital and can have the cytokine release syndrome managed. Now more and more we're learning we can give them outside the hospital, but you have to have a setup for that where you give the drug, carefully monitor the patients. And so you have to have all that set up, and not every oncologist's office is going to be able to set that up. It's still easier than CAR T-cell therapy, but it's still not so easy that every place can just do it, at like the way they can do Velcade or Revlimid. We're learning that these drugs have their own risks, and so it's because bispecific antibodies are usually given for a long time, they tend to be immunosuppressive, especially the ones that target BCMA. They kill the myeloma cells very effectively, but they also kill the normal plasma cells in the body. And remember, normal plasma cells are the cells that make antibodies. And so if you're on the bispecific antibody that targets BCMA, your body really can't make antibodies. And so you have to give patients antibody infusions. We call this intravenous immune globulin to make up for the fact that their bodies can't make their own antibodies to prevent infection. And that IVIG is a kind of cumbersome therapy to give. It's a long IV infusion. You got to get it every 1 or 2 months. So even though the drug itself, the bispecific antibody, is simple to give, it comes with some baggage with this need for all these measures to prevent infection. The drug talquetamab that targets GPRC5D, that has some specific toxicities that can really affect quality of life. And so the target for talquetamab, while it's mostly on the myeloma cells, is also on some other tissues in the body. And so that drug will lead the immune system to target some other tissues in the body, including the taste buds. And so patients on talquetamab usually have some diminishment or loss of sense of taste. It varies how intense that is. Some patients describe it as mild and annoying. Other patients describe it as profound to the point where they're really losing weight because they just can't eat the way they normally would. It can also cause problems for the skin and nails. Those tend to be less uncomfortable for the patients, but they are burdensome and unsightly. So that's some specific side effects related to talquetamab that are distinct to that drug and other drugs that target that same target. The other thing we're learning about bispecific antibodies is that over time, they can cause the myeloma cells to delete the target. And this is because we're giving these drugs we think this is because we're giving these drugs continuously. So where CAR T cells go in the body and grow and give you a really intense burst of activity against the myeloma, the CAR T cells tend to die off over time. And so after 6 to 12 months, the CAR T cells are no longer active in the body. With bispecifics, you're giving them continuously. And so the immune system is constantly going after that target for a long period of time, sometimes years. And what we've seen is that myeloma can kind of get around this by deleting the target of the bispecific antibody. And so you can have the myeloma start growing without the target, and that's the way the myeloma can escape. Now, what we've learned too is that if the myeloma deletes one target, you can then give a drug against the other target. So you have patients who progress on teclistamab and then respond to talquetamab by going after the different target. We've also learned that targets that go away can come back later. So we've had patients who delete the BCMA target, go on to get a drug that targets GPRC5D, and then they relapse later and the disease has BCMA back, and then you can give another drug that targets BCMA. So you play this cat and mouse game, and increasingly our labs are getting better at assessing myeloma for these targets so that we can be more intelligent about how we pick therapies based on the targets that patients have on their disease. Then the final thing, and this has really been a difficult thing to navigate, is that being on bispecific antibodies can make it harder to give patients CAR T cell therapy afterwards. And this is, I think you heard from Dr. Cohen earlier on, there is a general preference for patients who really are candidates for both of these therapies to do CAR T cell therapy first if they can and get bispecific antibodies later. Because what we've learned is that giving the bispecific antibody continuously over a long period of time is constantly stimulating the T cells in a way that messes up the T cells' function. And so when you then go to harvest T cells from the patient who's been on a bispecific antibody for a while to make CAR T cells, those T cells don't grow outside the body in the CAR T cell manufacturing process as well. And so we've learned that sometimes we can still do CAR T cell therapy for patients who have had bispecific antibodies, but you usually need to give patients a break to let the effect of the bispecific antibody wash out of the patient's system. And we are still, I think, although there's some ways around this, we think, trying our best, if patients can and want to get CAR T cell therapy, that we do that before we give them bispecific antibodies. But that's not a hard and fast rule for reasons I'll explain. So for all of those challenges, I think we have some solutions, though. And I'm going to kind of go through some of what we think is the future of how bispecific antibodies will be used. And hopefully you'll see that the future uses that we're developing do get around some of the challenges that I mentioned. So the first is to use bispecific antibodies as part of early line therapy. So we saw how CAR T cells were first approved for late line therapy. Now CAR T cells are approved for patients who have had 1 to 3 prior lines of therapy, so early on in the disease course. We think bispecific antibodies are going to follow that same path. And so we just in the last couple of weeks heard via press release that one of the first studies with teclistamab, the BCMA bispecific antibody, the first big phase 3 trial comparing teclistamab to standard myeloma therapy in patients who have had 1 to 3 prior treatments showed that teclistamab is much better in terms of what we call both progression-free and overall survival. So those are the key metrics of how well a drug is working. And so we think just like just like CAR T cells are approved for early line myeloma therapy, that we'll see bispecific antibodies like teclistamab approved there soon. And because bispecific antibodies don't have quite as much severe toxicity as CAR T cells, it may even be preferable for some patients to get bispecific antibodies as part of second or third line therapy and save CAR T cell therapy for later. Now, a patient who gets a bispecific antibody as part of second line therapy, for instance, will be on that therapy, if it works, for probably a long time. And because we know that bispecific antibodies can work for a long time in late line therapy, if we bring them up even to earlier line therapy, it could be many years that patients are on these bispecific antibody therapies. And we worry in that situation about long-term infection risk or having to give patients the antibody replacement therapy for 5, 10 years. That's really almost not feasible. And then, of course, we want to be able, if we use bispecific antibodies early, to be able to manufacture CAR T cells later for patients. And of course, we should think about the cost of giving a bispecific antibody for 5 or 10 years. We always talk about the cost of CAR T cells because that one dose is very expensive, but actually the cost of bispecific antibodies when you're giving them year after year is much, much higher than the cost of CAR T cell therapy. So that leads me to the next thing that I think or the practice I think we're going to be adopting in the coming years, which is fixed duration therapy for bispecific antibodies. And so what we are learning, we think, or at least we're trying to study, is whether patients who respond to bispecific antibodies can maybe take a break from treatment. And this is because, or at least we're thinking that, what makes this even possible to think about is that these bispecific antibodies are so potent and they work so quickly that you're giving the treatment for even almost like 6 to 12 months, patient has been in remission that entire time, maybe we can take a break. And what we've seen is that some patients who have had to take breaks from bispecific antibodies for side effects, sometimes they can stay off the drug for months and the disease tends not to come back. And so we, at Penn, in collaboration with Jefferson and a few other centers around the country, have started a clinical trial where patients who are responding to teclistamab, if they want to enroll on the trial, they stop therapy. And we just watch very closely what happens after that. And we're pleased to have some advice in designing this trial from HealthTree, and also support from Blood Cancer United, which is what the Leukemia and Lymphoma Society is now called, for this clinical trial. But we think if we see that fixed duration therapy gives similar results to continuous therapy, that patients will be able to enjoy time off therapy, that there would be lower infection risk over time. Maybe we would reduce the chance that the myeloma would delete the target. And also we would maybe be able to give the T cells a rest so that patients could go on to get CAR T cell therapy after a fixed duration bispecific antibody therapy. And then finally, of course, we would save a lot of resources by not having to give the expensive drug for years and years, and also to give the IVIG, which turns out to be pretty expensive too. Another approach that's being developed are what we call two-target approaches. And so I mentioned that one of the main resistance mechanisms for bispecific antibodies is that the myeloma deletes the target. And so if you could give bispecific antibodies against two targets at once, the myeloma deletes one target, it's still got the other target. And so you can circumvent that resistance mechanism. That's now been tested in clinical trials. Clinical trial combining teclistamab and talquetamab, the BCMA and the GPRC5D targeted antibodies, gives higher initial response rates than either one of them would be alone. And what's even more promising is that these seem to work for a long time. So when you give the combination, 91% of the patients who respond are still in remission 12 months later, which is better than what you would see, I think, with either one of these agents alone. You could also, instead of giving two different drugs, come up with a single drug that targets two targets. And so we call that a trispecific antibody. And there are now two different trispecific antibodies that we've heard clinical results from. So one is targets GPRC5D and BCMA in one molecule, so one drug that targets both targets. At this initial study that was presented of 30-something patients who received what we think is the right dose, 100% of those patients responded, which was really impressive. There's another drug that targets BCMA and CD38, so a different combination of targets, but also showed really promising results. And so we can target two targets with one drug in a trispecific antibody. What about three targets at one time? And so we can so there's a therapy from a company, Moderna, which you probably all know as the company that makes COVID vaccines. Well, it turns out that same mRNA technology that makes COVID vaccines, you can also use that to instruct your body to make bispecific antibodies. And so a clinical trial is just getting started that we're fortunately going to have available here at Penn, where you get an mRNA lipid nanoparticle, and that lipid mRNA tells your body to start making three different bispecific antibodies, one that targets BCMA, one that targets GPRC5D, and one that targets FcRH5. And of course, we don't know if that works yet, but it's a very promising approach to being able to target three different targets at one time. And then finally, what about combining bispecific antibodies and CAR T cells? So you could imagine giving a CAR against one target and a bispecific antibody against another target. Again, the idea of targeting two different targets to give the myeloma less avenues for escape, that may reduce the risk that the myeloma will delete one of the targets. And then in addition, because the way bispecific antibodies work is they activate T cells in the body, you can imagine giving CAR T cells and then giving bispecific antibody that will further stimulate those CAR T cells against the myeloma. And this was tested in a trial here at Penn led by Dr. Cohen, who you heard from earlier. We call it the STEM trial for sequential T cell engagement in myeloma. These patients got CAR T cells and then received after that the bispecific antibody cevostamab that targets FcRH5, so targeting BCMA with the CAR T cells and FcRH5 with the bispecific antibody. Dr. Cohen presented results at the myeloma meeting in September showing that if you look 1 year after CAR T cells in patients who got this combination, 93% of them were MRD negative at 1 year, which is, I think, better than you would expect just from the CAR T cells alone. And we hope to see this idea kind of investigated in other clinical trials going forward. All right, so I want to end by just talking about a couple of the clinical trials with bispecific antibodies and similar therapies that we have going on at Penn. We're really proud here in Philadelphia, and it was nice to hear Jenny speak earlier about the importance of subspecialty care in myeloma, and we're really proud here in Philadelphia to have several academic medical centers with myeloma subspecialists, and so we have Dr. Razzo here from Jefferson here today. There's another very nice group up at Fox Chase, and we all have different clinical trials, and we regularly talk and refer patients to other centers where there's a clinical trial that might be a good fit for a patient. And so these are just the ones relating to bispecific antibodies that we have at Penn. And so I mentioned earlier the trial of limited duration bispecific antibody therapy. So if you're on teclistamab, even if you're not getting it at Penn and you're interested in maybe stopping it, we actually can conduct this trial completely remotely by telemedicine, or you can keep your doctor wherever you're getting teclistamab. You just check in with us by phone. We talk to your doctor and we agree to stop the teclistamab and monitor very closely. And so we have patient participating in this trial from Virginia even. So we can do it remotely and with a lot of local monitoring, which is very nice. We just opened a big phase 3 clinical trial that's a global clinical trial to test whether teclistamab might be good as a maintenance therapy after autologous stem cell transplant for myeloma. So if you've just had a stem cell transplant or are thinking about that in the near future, after transplant, we usually do a low-intensity maintenance therapy, and there's a lot of reasons to think that bispecific antibodies might work really well in that setting, and so this is a big phase 3 trial to test whether adding teclistamab or using teclistamab as a maintenance therapy after transplant is a good strategy. I mentioned the trispecific antibody that targets both GPRC and GPRC5D and BCMA. I mentioned the phase 1 study that was been presented. There's going to be a phase 2 study of this approach, and we're going to have that one opening soon at Penn. And I mentioned already the mRNA therapy that targets 3 different targets will be opening soon. So thank you all very much for your attention.